Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
I'm here to present my case using Aggrastat with a short infusion. The purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who may not be familiar with contemporary use of 2B3A inhibitors. Here are my disclosures. I receive research support from Medtronic and Abiomed, and I'm on the Speakers Bureau for BI Lilly, Kiniksa, Janssen, Pfizer, and BMS. I receive financial support from Medicure for the creation of this video. Here is the patient presentation. This is a 59-year-old male with left arm discomfort the night before without nausea, vomiting, or diaphoresis. He was seen in the emergency room department with ongoing pain. Nonspecific ST changes were seen on the ECG with predominantly new T-wave inversions. He had no evidence of ST elevation. His cardiac enzymes were positive, suggestive of non-ST elevation MI. His history was notable for previous coronary artery disease with a prior ST elevation MI treated with a stent to the LAD and PTCA of a first diagonal branch 2 years prior to the current admission. The ejection fraction at the time of his prior STEMI was 35%, but had recovered nicely to 57% at his last assessment. His cardiac risk factors, including type 2 diabetes mellitus, ongoing tobacco use despite counseling to stop, dyslipidemia, and hypertension. He had stopped Plavix therapy after 1 year of dual antiplatelet therapy, and so now at the time of this new admission, he had been off of Plavix for 1 year. He was on aspirin alone. His catheterization showed occlusion of the mid-left anterior descending coronary artery in the stent with right to left collaterals partially filling the distal vessel. The patient was treated with PCI with an anticoagulation strategy of heparin and a short infusion of Aggrastat. Before describing the next steps, as a refresher, Aggrastat, or tirofiban hydrochloride, is a reversible antagonist of fibrinogen that binds to the glycoprotein 2B3A receptor, where it blocks the final common pathway to platelet aggregation. It has a 2-hour half-life, and the platelets return to normal function between 4 to 8 hours after you stop infusing this agent. Aggrastat provides very potent and rapid platelet inhibition and has a very consistent response for patients. Importantly, through its mechanism of action, Aggrastat has the ability to disaggregate an existing thrombus, which neither an anticoagulant like heparin nor a P2Y12 inhibitor can do. There are limitations to what thrombus it can disaggregate. Typically, it's most effective in a fresh thrombus. So back to our case. Here is how we decided to proceed. The patient was treated with PCI with an anticoagulation strategy of heparin and short infusion Aggrastat. As you can see from the attached images, the clinical result looked good after PTCA and stent placement. Following stent placement, the patient was loaded with ticagrelor and aspirin immediately post-successful PCI. We decided to continue the Aggrastat infusion for an additional 2 hours after the stent was placed to protect the patient during that early window of vulnerability until the ticagrelor load had become effective. So here are some takeaways from this case. Aggrastat can be used with short infusion. In this case, the patient had an in-stent occlusion of a mid-LAD with right to left collaterals and required a short infusion of Aggrastat. Prompt and early use of Aggrastat during PCI can help with intraprocedural pharmacological management of the thrombus to achieve successful results with thrombus resolution. Aggrastat use facilitated a successful PCI in this patient who had an in-stent occlusion and required a short infusion. Thanks for watching, and if you have any questions, please reach out to the Aggrastat team for more information.